Perfect. Okay. All right, well, welcome all. Thank you so much for coming. So the title of our presentation, Rules of the Road for Publishing Quality Improvement Research. So this is geared towards your operations folks, your junior researchers, senior researchers, if you're trying to guide your operations folks. And so we hope you guys can kind of find some benefit from this. Our obligatory disclosure slide. So objectives, we want to differentiate the difference between quality improvement research and the big scary word implementation science. We want to really describe how to bridge that gap between a quality improvement project into really turning it into a research study. And understand the differences between what is true QI research versus the traditional clinical research that we're familiar with. And then the last part of it is to apply that kind of QI process from design to IRB protocols to publications. And we have some examples at the end, which is the audience participation point. So we'll jump to the bottom line first, in case we lose your attention between now and then. So QI, I think people think it has to be retrospective, but it can be prospective. Again, it can be published and turned into what we consider true research. I think the overarching goal is that it's all about the intent. When you go into a QI project, what is your intent? What are your goals for that project? And that can help shape if you can really turn it into research.
Dr. Davis, what's the matter? You look rough.
Well, I just had my review with the chair, my annual review. They said I need to do more publications and research, and I don't have time for that. Like, I mean, I have a family. I'm on like 6 committees. I have to do this teaching stuff. Like, it's just so frustrating. I feel like I just don't have time to do all that stuff.
Well, you look rough, and that sounds rough.
You probably don't get it, being a research director and all. I mean, you put out like 2 publications a week. I mean, what's your secret?
Well, I try to publish what I'm actually working on.
Well, what do you mean by that?
Well, for example, you're on the sepsis committee chair, right? You're the chair of the sepsis committee, right?
Well, yeah.
Well, what you've done some really great quality improvement work for our sepsis care, right?
Well, yeah.
Well, why don't you try to publish that?
Oh, I guess so. That makes sense.
My point exactly. We're going to tell you how to do it.
What are we doing?
Raise your hand if you've had that conversation before on either side.
Great. So when we talk about it here, like there's papers that go in depth about what is implementation science, what is quality improvement, and what is like regular hardcore quote-unquote research, right? All of these are very rigorous ways to publish the findings that you have. And that's just the key, is what do you have? Do you have something that's novel, that's never been tested before? Well, then you're going to need a clinical trial, right? Because you don't know whether or not that's going to work. Is this something that is being used in another shop and you want to implement it in your shop? Well, then that's something that could be either quality improvement or implementation science, depending on how you do it. Or are you just looking at processes within your own shop and you have made things work better and you want to share that information with the rest of the world? Well, then that's quality improvement, right? So you just have to take what you have and what data you have and then try to fit that into the right place. And the right place is how we're going to discuss the differences between the 3 different types of research.
And to kind of build upon that just a little bit, we're not really talking about the implementation science aspect, but really just kind of very broad level, high level, what is this distinction? We talk about, people throw around the term research, and people think it has to be bench research, lab research, it has to be a clinical trial, et cetera. And there's some nuance in that. But if we were just to kind of differentiate in regards to thinking about this from a quality improvement side, generally, what is the goal and the intent as we talk about? It's really about you see something, you observe something, you want to improve the care within a given setting. And then in terms of research, it's usually novel or it's a question that hasn't been asked, something that you want to actually see. Is there the evidence base, or can we actually create or demonstrate the evidence base that can become generalizable knowledge? I think the setting is actually really an important thing. We say typically quality improvement is usually in a single institution, but it's probably more than that. It's more about the setting is the locale in terms of where you're observing something that's happening, and then you think that maybe there's something that we can either improve that you standard of care, a best practice, that you actually want to actually test and then actually work through that process to go. In terms of research, that may vary. I mean, when you have a traditional clinical trial, you're really thinking about the class randomized double-blind controlled trials, and you really have to control that setting. And so you have to kind of remove any of those kind of confounders or anything like that. The intervention generally for quality improvement is, like I mentioned, it's something either that you there's standard practice, there's best practices, it may be coming from the regulatory side or from the compliance side, and now you actually have to kind of implement it. So how are you going to actually improve those numbers so that your institution can actually achieve some of the outcomes that's intended that now may be tied to some reimbursement, et cetera, in the livelihood of your institution. In terms of the intervention for research, typically, I mean, it's usually new, it's a novel question you're trying to actually see, is it beneficial, is it not, or is it actually trying to establish network voice. From a statistical standpoint, how are we going to analyze this information? From a quality improvement perspective, we call this quality-based, and it's actually really kind of drawing a little bit more from process evaluation or program management, if you will. So, I mean, we can actually kind of introduce things like, you may have heard of Plan, Do, See, Act, and kind of all those different components. Those are actually metrics that you can actually track in terms of process evaluation to look at those different steps to actually say, was there an impact, was there not? Typically, in terms of research, you're really thinking about the more traditional biostatistical analyses, whether it's Bayesian or empiric. Oftentimes, the quality improvement is local to the population where you are working. That can be a single institution, but it may be a population itself that you're looking at. And of course, research may vary. It could be single institution, it could be multiple, it could be actually international, if you will, too. Now, the last two, I think in terms of, where people oftentimes get tripped up a little bit. Is IRB approval needed? If it's a single thing where in your shop, in your institution, in your hospital, your D, you're trying to actually improve something that's directly related to patient care, oftentimes IRB is not required because that is actually part of the daily patient care, and you're just trying to improve the outcome of the patient care itself. However, if at some point you feel like you found something or you've seen something and you actually want to disseminate that information, that is where IRB approval is needed. However, the type of IRB approval is not the full convene that requires a lot more scrutiny and a lot more preparation, but it's typically either expedited and or exempt, because oftentimes it's actually really looking at either retrospective or observational type of data. And then in regards to being published or not, sometimes it may be beneficial. If you see that, hey, there are some best practices that we can actually share and disseminate, and that's worthwhile, that oftentimes leads to that distinction whether or not you're going to end up getting an IRB approval that was expedited or exempt, is if you have that intent to publish, and it can be published. It does not. It may just be internal to your institutions where you just want to be able to share that and actually improve the process and track it over time. And if you actually develop a larger body of data or information that becomes worthwhile in terms of publishing, that may go through that path of publication and then pursuing that. And then generally, I think the aim of research is really dissemination of novel therapies, novel approaches, and really providing that evidence base. So just to kind of distill like the presentation we did, if we were to try to think about, research is really about clinical trials, establishing that evidence base. Implementation science, which we haven't really dwelled upon very much, but it's really about how do you translate something that is evidence-based into normal day, real world practice, and or to scale. And then when we think about quality improvement, the simplest way of thinking about it, it's a process. It's a process evaluation, it's a process that you're actually looking at. So then you kind of descend upon, there is some overlap. So when when you're there, what do you do with that? You're kind of like, I'm not pure research, I'm not pure, just operations, and I'm not just kind of someone that just wants to do implementation.
So instead of kind of ignoring the gray zones, we're going to highlight a little bit about the gray zones. So QI, can be published in and of itself, but one of the things that you need to be mindful of is that QI can sometimes transform over into research or kind of have that gray zone with research. And there's some instances where you might want to consider that. So for example, if you're thinking about randomizing a group to something, you really need to be thinking that's most likely going to be research if you're randomizing someone to it. A quality improvement project should be something where you already know what is effective and you're trying to implement that. And if you have any like new product or process that you're trying to get through that's something that's not been validated kind of elsewhere, or if you're doing anything that's experimental or quasi-experimental, those are the instances where you really want to consider that early kind of IRB approval, because you really may be kind of crossing over into the research realm, and you really don't want to involve human subjects ethically in something that's not been proven without having kind of put some thought into that. And the bottom line that we really want to stress is this is all about the intent. So what is your goal? Is your goal to identify something that's new and to generalize that for some new form of care, or is your goal to bring something that's worked elsewhere into your practice setting and to get your practice setting up to some certain kind of standard or quality in some way or shape? So there may be a process somewhere else that works that you want to see implemented in your institution, or there may be some goals that all of those metrics that we're all held to, the sepsis police or the stroke police or the quality improvement police or the patient experience police or whoever are coming to you, and you may have metrics that you want to meet, and you may not have the best process, but that's where you do that PDSA kind of cycle to kind of get to a goal that is a standard that's effective. And then just one other way to kind of embrace the kind of the gray zone here is to look at kind of the overlap between research and then kind of operations management, and then also to consider kind of some policy implications as well. So implementation science really falls in that area right between research and operations management. And so that is actually the science of studying how to implement those things, whereas quality improvement is the process of implementing something and making it better. Implementation science is actually studying how to implement those processes. So just like we study how we teach and education, and people study kind of statistics and how to do statistics, this is the science of how to actually implement things once you know they're effective, which, as Dr. Lin was talking about, research trials take out all of the variation, and those show that things are effective in very controlled settings, but we also need pragmatic data on how to implement those things and make them effective in the real world. So some of the guidelines for those of you who are new about publishing, so Squire is probably the best one for quality improvement research, and so it literally gives you a checklist guideline of how to write your publication, and most major journals that publish quality improvement research will use that Squire guideline. And then most of you may be familiar with Consort and Strobe. So Consort is the main guideline used for kind of clinical trial reporting, and Strobe is one of the major guidelines used for kind of observational data. But I would strongly recommend either getting with someone who has familiarity with these guidelines or reading through those Squire guidelines yourself. It literally is a step-by-step process that tells you how to write your publication.
We can pause here for just a second. Does anybody have any questions on the content and the descriptions that we laid out before we get to the interactive Jeopardy portion? Yes.
Can I ask you, so for implementation science, can you look at implementation science as part of quality improvement? Like, if you don't know something works, yet like that, and I'm thinking about like if you're implementing like some intervention, like a huddle or something, that to talk every morning and do whatever, you don't know yet whether that's effective. But like when you're looking at whether it's effective, can you look back and look at stuff like adoption of fidelity or whatever and say, well, maybe it wasn't effective because they didn't actually meet every morning for the huddle, like that sort of thing?
Yeah, go ahead.
Yeah. So first and foremost is a plug for the 2 o'clock session on implementation.
Yes. We have a follow-up implementation.
But I think to your point, because I think, implementation science sounds like a scary word because it's like this new thing. And it, honestly, if you kind of peel off all that stuff, it's not really all that new. In some ways, it kind of is like a logic model. It's about inputs, it's about outputs, and it's about outcome. Now, given that, you can use it to actually plan how you're going to implement a program, but you could also use it retroactively or retrospectively to see how did the design or the delivery of something how did it actually fare? Were there areas where you could have improved because you took into account some of the contextual factors in implementation science? So all of the implementation science is actually really trying to recognize in a more formal structure things that you need to consider to actually lead to that improved process itself.
To your example, when you're thinking about like designing this new huddle process, you would think about, okay, I want to look at what was the percentage of times that we had decided we should have a huddle and we actually did have a huddle, right? And then maybe you can compare it to what did the volume look like that day? Was there like a correlation on really like high volume days we didn't have a huddle. Again, that's more of like an association, but saying that kind of played into it. So those are like, when we talk about the intent, what are those outcomes that you're thinking about? And that's what you would look at. We'd want to like measure or have some way to measure before you initiate that process.
Right, that's the key, is that you want to make sure you have something that's a product at the end. Nothing's worse than somebody had a great idea and stuff like that, and maybe made some changes, but we don't have a good output measure, or we don't know what we started with, right? And trying to work backwards from that is really difficult. So that's why sometimes looking at the squire or looking at that, if you're at the implementation phase or the beginning phases, really helps, because you want to be able to have a definable output variable or something that somebody wants to read. That's the key, is you want to have something that was changed, something that was better, something that got better, and something that you can measure, right? That's the other side of that, right? So that's why going through some of those guidelines and stuff like that are really meant to help you to kind of frame what you want to do, so that way you have something that's an input that can be measured, and then you have an output, aka something you can share with the world.
And then just the intent being the important part, I would kind of stress too. So if you are in that bucket where you've kind of already done something and you just want to go back and look at it, that doesn't mean you can't do it. Your intent initially was to do a quality improvement process, and then at some point you decided, hey, like this worked really well, I think other people will want to know that, and that does turn into implementation science, but that doesn't mean that you did something wrong in the first place because you didn't kind of start that way. It's just kind of, that's the way the world kind of works.
Yeah. So with that, we have 6 examples of different type of QI turn research. So if you guys pick whichever, we're hoping to get through 2, but it's really kind of up to
Yeah, we need someone to pick a topic so that we can tell you. We have 6 and we're only going to do 1 or 2 of them. So somebody needs to raise their hand and be brave and pick a topic.
Ooh, love it.
Ultrasound.
All right, let's do it. So this was my kind of project that I did in residency. So this was using point-of-care ultrasound and MRI to do a radiation-free kind of diagnosis of appendicitis in children. This was done because we already had an MRI process in place, had already studied and had a rapid MRI that takes about 40 minutes to do for kids to diagnose appendicitis without using CT. And then the point-of-care ultrasound was actually 2 of us who were already doing the point-of-care ultrasound. And we were already tracking these kind of through our QI process from kind of point-of-care ultrasound. So this was kind of exempt from the IRB, and basically the limitations we had was there were only 2 of us kind of doing the point-of-care ultrasound, but the rest of the institution was already doing the MRI and had already actually studied it compared to CT. And so basically what we did here was look at kind of different outcomes on the process that we were already doing, which was using point-of-care ultrasound and MRI, and looking at how that compared and how we could expedite basically time to diagnosis, time to OR, and kind of what the accuracy rates were for both of these things. And we had this data set that we actually, after we had gotten the exemption and used it, we actually got 2 or 3 other publications out of the same data set because we had already pulled all of the charts. We could look at other variables like labs and time to onset and stuff like that. So that was very helpful for us. Point-of-care ultrasound is one of the areas that's very ripe for this kind of research implementation, because we have a lot of instances where we know ultrasound is helpful and a lot of people who aren't trained or kind of experienced with it. So does anyone have any questions about that project in particular? Oh, you want to do the next one?
Yeah, what's up?
Okay, go for it.
Can we do the chronic disease?
Sure. It's perfect. Go for it.
All right. So chronic disease, that's something that you typically think of as that acute hypertension. So just to preface this is going to be focusing on diabetes, and I think the question was, should we be screening for chronic diseases, for example, diabetes in the emergency department? And part of this was actually informed by, from 10 years previous, really the implementation of opt-out HIV screening in the ED. And there's a lot of other literature related to the benefits of that. Part of the reason why we want to look at this is we know, based off of, 1, U.S. prevalence, it's extremely prevalent disease, and so there is some benefit in terms of overall screening. It's typically recommended in the primary care setting, but we oftentimes know in the ED that we function as a safety net. People that either don't have adequate access to care or don't have the literacy to know exactly how to access that care, we wanted to actually see, are we able to, 1, create a screening system that's automated that actually minimizes any kind of impact on the ED workflow, and are able to look at linking these people into care and identifying some of the demographic variables. So what we did was we actually adapted our EHR-based screening for HIV to diabetes and utilized an A1C, and was informed in terms of the eligibility criteria off of USPSTF guidelines. So generally, broadly speaking, because there are some subtleties between American Diabetes Association and USPSTF, but effectively it's, age over the 45, no previous diabetes, no previous A1C screening in the previous 3 years, and then also if you happen to be younger than that, had a BMI greater than 25, meaning that you had some indication of obesity, to actually get screened if you had not been. So this was actually published earlier this year in JAMA in terms of some of our preliminary stuff. So it was like the first 6 months really of data. And what we had actually found was 50% of the people that actually were eligible for screening actually had an abnormal result. So that was, and it's pre-diabetes and diabetes. That being said, 70% were pre-diabetic, 30% were diabetic. Not necessarily surprising, that's what you would actually expect. What was surprising to us is that when we actually followed up with them, 70% of those people did not necessarily know what their quote status was, that they actually were pre-diabetic or diabetic. So obviously this is actually something where when we're thinking about, can we implement some of these more preventive health screening and or proactive kind of emergency medical type of things of identifying, linking to care and downstream potentially improving outcome, that's something that we found. And the other thing too, we are located in an urban city of Chicago, kind of very underserved and oftentimes underrepresented population. And so I think part of the thing is that we're also seeing in terms of the demographics, definitely kind of sways with the African American population as well as the Latinx population that we're seeing, and also subtle age changes where we're actually seeing younger population in terms of those people that are screening positive. And so for something like this, we actually were able to do it expedited, partly because we were more evaluating the program as opposed to kind of testing anything related to that.
Okay. So I think with that, we are at 25 minutes, and we know there's a 11:30 speaker. So just to kind of summarize, again, QI can be perspective, even if, if you've done the project beforehand, that's fine, that is retrospective, but you can think about it ahead of time. It can be published, that's where you probably want to get your IRB involved. And they usually give you a sentence, or they'll kind of give you a sentence saying, this was reviewed by the IRB, determined not human subjects or expedited, and that's your sentence in your publication. It's basically formatted for you, so you don't have to come up with it. And then again, it can be turned into research if you are doing that randomization, if you're looking at something new or experimental, and it's just all about intent. It's just kind of thinking, what is the goal of this process and what do I want to try to get out of it, and being very intentional in how you start to, either you start it or where you are, or how do you continue to run it if you have an end product.
And it could be, like you said, the example here is that we already do ultrasound in our shop. We just want to ultrasound in our shop, or something prospective. Hey, diabetes is a big problem. How do we integrate this into our EMR to make it something that's otherwise prospective, right? So it just depends on what you have, what you want to look at, and what gets you up in the morning, right? What are you excited about writing about and trying to find and work on and stuff like that. So
Thank you so much.
So this is our contact information. If anybody has any questions that they want to get to us with, there's my Twitter, and then all of our emails are there as well. So we'd love to entertain questions. This is something that we all have a passion for. So if anyone has any projects or needs any mentorship or advice, please kind of reach out to us. We're happy to do so.